So this video is going to introduce the next segment of our respiratory section, which is obstructive and restrictive lung disease. So we're going to begin by distinguishing between obstructive and restrictive lung disease. So first of all, obstructive disease, this may sound oversimplistic, but it'll require more clarification as we move through the conditions. Obstructive diseases have some form of obstruction as part of their pathophysiology. This could be anything from an airway obstruction like an object, like a grape or something like that. Or it can be some pathophysiologic change to the tissues that cause an obstruction in flow either into or out of the alveoli. Restrictive lung diseases also impede flow, but it is not because of an obstruction. It is because there's a restrictive process that's limiting the capacity of the alveoli. Another way to say that is the alveoli can't open and subsequently close because the tissue has changed in such a way that it restricts the expansion of the alveoli. If you think of trying to blow up a balloon that someone is holding in their hand, you can only inflate that so much if they're holding on tightly because there is a restriction. So in other words, there's a limit to the capacity of the lungs to expand, whereas obstructive disease, the limitation is based on something that's obstructing the flow either in or out. So we'll start with obstructive diseases. So what you have here are three different depictions, cartoon representations of an obstructive type of lung disease. So the first image, image A, you have a relatively normal lung tissue that's reflected in the blue circles that have the blue dots in between them. That's the structure of the lung itself. In this case, let's think about the airway like a bronchial or a bronchus. The anatomy is normal in its shape and contour and texture. The black lines that come off of that look like tree branches or blades of grass, whatever you think of there, those black lines represent connective tissue. And in this case, you can see that I'll tell you that those black lines represent what would be normal connective tissue. So in example A, the connective tissue is fine. The lung tissue itself is fine. What you see in the center, the black line that cuts the airway about halfway, and then all the black dots, that reflects mucus or some kind of solution that is in the airway itself that is obstructing flow both into and out of that airway. You could think of a mucus plug. You could think of secretions that people cough up from their lungs. There are a variety of things that could be represented by that black. In this case, there is mucus or some type of solution that's creating the obstruction. The middle example, if you'll notice the blue section, the blue circles with the dots, that section is thicker than the blue section in example A. This reflects inflammation, an inflammatory process in the lung tissue itself that's causing the airway, which is represented by the white portion in the center, which creates a smaller airway. So now that inflammation is creating the obstruction. I'll point out again, the connective tissue surrounding these structures is relatively normal. It's normal in density, it's normal in number, and it's normal in its connectivity to the lung tissue itself. You'll notice the inner lumen in B is significantly smaller than the overall inner lumen in A. However, the white area in B is small. compared to that inner lumen in A. However, it is comparable to the diameter of the actual white space that's in A. So both of those, you can see an obstruction in the airway. Example C is a different pathology altogether. So in example C, you'll notice that the connective tissue, the little black lines, have disconnected from the lung tissue themselves, and there's fewer of them. So we've lost connectivity here. When that happens, the lung tissue does not have the elasticity around it to help hold it open. So you have a boggy lung that collapses very easily. You'll notice that the overall white space in the center of these three lumens is about the same. There's three different pathologies that are going on here. You'll also notice the contour of the lung tissue itself. That's the blue circles with the dots. The lung tissue in example C is, you can see that the lines aren't nice and well defined and drawn. They're kind of squiggly in nature. This reflects that collapsed nature of this airway. So we have three distinct pathologies here. It is important to remember this as we go forward, that patients that you're going to encounter in clinicals don't have one or the other of these. There will be patients who have A, but they also have A and B. And patients will have A and B and C. And people will have B and C. Patients will have A and C. So there will be a combination of pathologies that go into different people's lung conditions and subsequently how we manage them as healthcare providers. So there are these four major categories, and one of those categories has three distinct manifestations. So obviously airway obstruction is its own distinct type of obstructive airway issue. And we'll talk about that in a moment. Obstructive sleep apnea is a different matter altogether. There is an airway obstruction. It is not from a foreign object. In this case, it is a matter of the shape and contour of one's own physiology that's creating that, one's own anatomy that's actually creating the obstruction in the case of obstructive sleep apnea. And that could be a combination of both the airway itself and someone's body habitus, their shape and size, and body surface area. Chronic obstructive pulmonary disease, COPD, has three manifestations that have distinct properties. However, they can occur together, and we will discuss that as we move into both emphysema, bronchitis, and asthma. You will see these grouped differently by different textbooks. I describe COPD in this class as an umbrella term that gets used to capture several chronic conditions or a few chronic conditions. So by definition, chronic obstructive pulmonary disease. Each of these three, emphysema, bronchitis, and asthma, are chronic conditions. They're obstructive conditions and they're pulmonary diseases. So I put them in the category of overall chronic obstructive pulmonary disease. Some people will group emphysema and bronchitis together and then address asthma separately. And some people will say emphysema is really the only chronic obstructive pulmonary disease. They'll use those interchangeably. For this class, think of COPD as an umbrella term inclusive of emphysema, bronchitis, and asthma. Cystic fibrosis, we'll touch on this more when we discuss pulmonary fibrosis. Cystic fibrosis has both properties of obstructive diseases and restrictive diseases. And as we discuss it, we will clarify what's meant by that. Airway obstruction is something you are introduced to in basic life support. So in this case, if someone has an airway obstruction, do they have lung sounds? The answer to that question is going to be no, because the definition of an airway obstruction, foreign body, particularly airway obstruction, is that the airway is occluded, and the effective treatment for someone who has an airway obstruction is the Heimlich maneuver. Remember, they teach you if they're not coughing or making any noise. If they are, then they don't have a complete obstruction and they're moving air, and a cough may release that obstruction. So with a true foreign body airway obstruction, the patient does not have lung sounds. There's no air moving in or out. This is a life-threatening emergency. Simply stated, the intervention is to remove the obstruction. This is the function of the Heimlich maneuver. Depending on the type of obstruction and the clinical scenario, that may be insufficient to address the obstruction. An example being a mucus plug or some type of object that has gone too far down the airway and a cough is insufficient to dislodge it. In that case, we have to go after it with a bronchoscope, or perhaps if it's mucus, then we could use a suction catheter. Remember this, if you haven't heard this from me a few times already, you will hear it a whole lot between now and the end of the semester. We're going to treat the problem and manage the symptoms. So an example here would be, you have this patient on the monitor and their oxygen saturation is 85 and dropping, 85, 80, 76, 72. Putting oxygen on them is not going to help. That's managing the symptoms. We have to treat the problem. We have to alleviate the obstruction. So in this condition, we have to ask ourselves the question, what's causing the obstruction? And I've included several examples of items that are causing the obstruction. If a penny is causing the obstruction, that intervention is very different than if inflammation is causing the obstruction. Two very different treatments. You can't take forceps into an inflamed airway and alleviate the obstruction. A bee sting, for example, would be an example of how an inflammatory process causes the airways to swell. Again, Heimlich maneuver is not going to help. We need epinephrine for that. Mucus or ET tube occlusion, we need suction for those kind of things. If an antibiotic is doing it, most likely that's an allergic reaction. We're going to stop the antibiotic and possibly give epinephrine, inhaled racemic epinephrine, or Benadryl. An asthma exacerbation gets a completely different treatment than any of those. An asthma exacerbation is going to start with inhaled corticosteroids and bronchodilators. We want to decrease the inflammation at the site and put them on bronchodilatory medications, which we'll talk about later in this course. However, we may have to, if that asthma exacerbation escalates, and we'll talk about this with asthma, if it escalates, even after bronchodilators, we may have to give them epinephrine as well. Sleep apnea, once again, treatment very different from the other type of airway occlusions, as well as like a neoplasm or a mass. Scoliosis can cause a profound curvature of the spine that I've had patients completely obstruct a bronchus because of the scoliosis. So each of those conditions have a different resolution, a different treatment of the problem. Obstructive sleep apnea is an intermittent interruption in breathing. Generally, for at least 10 seconds or longer, a period of apnea or not breathing during sleep. That's why it's called sleep apnea. This is characteristically diagnosed with a sleep study, and there are a variety of risk factors that contribute to the likelihood of developing or having obstructive sleep apnea. First of all, being male. Obesity and thick neck, those two things also increase the likelihood of developing obstructive sleep apnea. The tissues in those areas are increased in size and can then cause obstructive issues, particularly when the muscles of the upper airway are relaxed when someone's sleeping. As we advance in age, the muscle tone of the upper airway starts to lose its tonicity. That can also contribute to sleep apnea. And as being male is a risk factor, postmenopausal females have a higher risk, again, possibly related to the decrease in estrogen secretion after menopause. The obstructive sleep apnea causes an increase in interthoracic pressure, which can then ultimately show up by creating problems with the heart and other lung issues. When I'm referring to heart and lungs in this case, you're saying, they're already having trouble breathing. That's absolutely true. Specifically, obstructive sleep apnea generates these increased interthoracic pressures, which can cause conditions such as right-sided heart failure and pulmonary hypertension. Often the pulmonary hypertension is the first result. Those increased pressures in trying to exchange oxygen result in changes to the pulmonary vascular bed, which subsequently increases the workload, the resistance that the right ventricle has to face as it tries to pump blood from the right ventricle to the lungs. Those can cause, left untreated, that can cause pulmonary hypertension, ultimately a condition called cor pulmonale, myocardial infarction, and possibly even stroke. The primary treatment for obstructive sleep apnea is going to be positive airway pressure. Commonly, the first intervention for patients for obstructive sleep apnea at home is a CPAP machine, continuous positive airway pressure. Alternatively, in the hospital, we will treat patients with BiPAP, which is a bi-level pulmonary artery pressure device. Emphysema is a different pathology altogether. So in this picture, or in this slide, I have a few pictures to kind of represent what the pathology looks like. If you recall the cartoon image from earlier that I showed you, the one on the left here at the bottom, you see a depiction of what is normal and healthy lung tissue. You have a normal internal diameter lumen, a normal internal lumen of the airway represented by this white area, the normal thickness of the pulmonary tissue or the bronchial tube itself, the bronchial airway, and normal connective tissue, elastin and collagen, to provide the structure for this airway and to maintain its open integrity. With chronic obstructive pulmonary disorder, specifically emphysema, you have a deterioration of the connective tissue around the airways. That's represented by the decreased number of black lines that I'm pointing to here as I move around this circle. Those black lines, there's fewer of them, and there are even fewer of those that are actually connected to the airway itself. So we lose not only connective tissue, but we lose the attachment of some connective tissues to the airways themselves. What this creates is a very limp, boggy connective tissue, very, very soft and mushy. It almost can collapse upon itself. And in fact, if you look at the bottom radiograph picture, actually it's electron micrograph picture. If you look at the electron micrograph B to the very far right of the slide, you see how the air, you say, well, those big dark spaces are bigger. Yes, they are, because they have collapsed into each other. And subsequently, there are so few connections here that these big sacs can't conduct air in or out. They essentially trap air in the form of CO2 in these large luminal spaces. Above it, in image A, that electron micrograph shows you what normal alveoli look like. In this case, you have thousands and thousands of small alveolar spaces, and you can see white connective tissue holding their shape and integrity. This allows that tissue to be able to open and close as an individual inhales and exhales, allowing the tissue to functionally exchange air. So not only is air exchange impaired in this bottom image, but as the connective tissue around these sacs breaks down, so also does the vascular tissue around this space. So in this case, in the bottom image, you now have several alveoli that have collapsed into each other, creating these big boggy spaces, and you've lost the vascular bed around these big spaces. So now we don't get oxygen moving into the bloodstream because the bloodstream's not there around these sacs. This next image reflects what I was just saying. So if you look at the top picture, this reflects, this is a histology slide. And in this case, the slide has been stained in such a way that red blood cells are pink on the slide. And if you look at the top slide, you'll notice that there's a high density of pink tissue all over this slide, interrupted by small little pockets of what look like little ponds or lakes. That's open air space. Those are areas where gas can move into its cross-section of an alveolus, so gas can move into an alveolus. The point there is that each of those white spaces in image A are surrounded by a high degree and a high density of vascular spaces. If you look at the bottom slide, you'll notice that there's lots of white space. So in this case, those areas that look like ponds or lakes, which are actually cross-section of alveoli, are quite large, much larger than in image A. This means that all of those small alveoli that used to exist close together as in image A have now collapsed into each other, creating these very large, boggy alveoli. You also notice there is significant reduction in the amount of pink tissue, which, as I emphasize again, the pink tissue is actually vascular space. You have to have oxygenating space and vascular space in order to get adequate diffusion into the vascular space and subsequently adequate perfusion to the organism. So with emphysema, what has evolved here is neutrophils neutrophils being your own defense mechanism, begin to break down lysosomal elastase, which produces the destruction of elastin. Elastin, related to the word elastic, elastin provides the stretch capacity of the tissues. It holds the tissue taut and allows it to both expand and contract, much like an elastic band in a pair of pants or anywhere else you may encounter that. It allows the stretch and contraction. Also, the neutrophils break down collagen. As collagen breaks down, this destroys the strength of the alveolar and vascular walls. Collagen provides, much like rebar in concrete, collagen provides the strength to that connective tissue elastin providing the stretch so that now it is both strong and elastic. So our alveoli, when they're normal, have plenty of collagen, plenty of elastin, so they can maintain their integrity. They can expand and contract as we inhale and exhale. That elastin draws the alveoli back together, which help us exhale. When you break that down, as the images have depicted, you can see that the alveolar walls dissipate and they lose their integrity. The biggest two contributors here are cigarette smoking and pollution. Cigarette smoking being number one. Cigarette smoking stimulates macrophages, which then stimulates neutrophils. This is just the fact of what cigarette smoking does when you inhale cigarette smoke into your lungs. It's going to activate macrophages, which then activate the neutrophils to create this process. Air pollution can similarly do this, can similarly have the same effect. Heredity, the hereditary component here is an alpha antitrypsin deficiency. That's the genetic component that may be contributing. And while a lot of people would love to say, I have an alpha antitrypsin deficiency that's causing this problem, most likely in most of the cases that we encounter out there in the world today, the highest proportion of those are going to be a result of cigarette smoking, either firsthand or secondhand cigarette smoke. So that said, assessment becomes the key. So we begin with health history assessment. And so this would be exposures. Did you smoke as a kid? Did your parents smoke while you were a kid in the home? Did they smoke in the car while you took long family trips? Is there any other family history? Were there members of the family who had COPD without a smoking history? That would be sufficient or significant, I should say, to point toward alpha antitrypsin deficiency. Incentive spirometry becomes critical for these patients. With emphysema, the likelihood that they're going to continue to lose alveolar tissue is very high, almost 100% that they're going to over time lose more pulmonary tissue and alveoli. Incentive spirometry helps us establish their vital capacity. So it helps us know now how effective, how much oxygen they would have the capacity to exchange, how much tidal volume they would functionally be able to use. So in establishing that baseline, it can give us an idea over time how quickly, how slowly they are deteriorating with their condition. Also, incentive spirometry is one of the, beyond that, is one of the best exercises these patients can do to maintain the integrity of the alveoli that they currently have that are functioning. So incentive spirometry becomes a key element both as an assessment and also as an intervention and a maintenance practice for these patients. I mentioned here the Larry King pose. If you are familiar with Larry King, the journalist, when he was on TV, as he would do interviews, you would notice him constantly leaning forward with his elbows on the desk as he interviewed people. This you'll hear other people refer to as tripoding. So they are literally leaning forward as if to put their body in a tripod position to essentially capture alveolar space that they don't typically use. As we've talked about before, we characteristically breathe with the anterior upper portions of our lungs, just by the way we're oriented in space and the composition of our internal organs. This allows the heart, this tripoding allows the heart to shift forward, creating more space in the back of the chest, in the posterior portion of the lungs, particularly the upper posterior portion of the lung, which help these people feel as though they can breathe better. You'll also notice these patients using accessory muscles when they are having severe distress. These would be muscles of the neck as well as intercostal muscles to help force the air. You'll see those muscles stand out as they breathe. Another thing to assess for is crackles. Crackles here is not, in this case, being caused by fluid in the lungs. Now, you will have patients who have a complicated presentation and they have both fluid in the lungs and they have emphysema. They may have pneumonia, which set off their emphysema, which causes crackles. If they're not in a condition where they have fluid in the lungs, they still may have crackles as a result of the atelectasis from emphysema. So, crackles alone do not necessarily mean the presence of fluid. With emphysema, it reflects the lack of function of some alveolar tissue. Hypercapnia is a classic symptom for emphysema. You'll remember hypercapnia from our discussion of arterial blood gases. Hypercapnia is elevated CO2. This is chronic. In this case, it's chronic CO2 retention. These patients will have baseline elevation of their CO2. So often you may hear people refer to them as being in the 50-50 club. Their PO2 is 50% and their PCO2 is also 50, not 50%, 50 millimeters of mercury. These patients can have CO2s higher than that, but this is part of the problem. If we begin to correct that, if we try to drive their hypercapnia down to a normal range, we may actually put them into a worse condition and cause a metabolic alkalosis for them. Because of their chronic hypercapnia and their chronic hypoxemia, these patients develop a condition called polycythemia. They increase their number of red blood cells. So the red blood cells could be high, or it could be normal in conditions where there should be normally low. This is the body's way of attempting to compensate and maintain homeostasis. So the body then says, well, if we're going to keep this high CO2 and have trouble, we need to make more red blood cells so that we'll have more red blood cells to carry the little bit of oxygen we are getting and perfuse the tissues. That's what's meant by poly meaning many, cythemia referring to blood cells. So polycythemia is a side effect of this hypercapnia and hypoxemia. The hypoxemia we only work to correct if it's severe. So just because their PO2 is 50 doesn't mean we're going to run in and throw a bunch of oxygen on them. Because of this polycythemia and their chronic hypercapnia, adding oxygen can sometimes cause these patients to quit breathing. So in this case, we're going to monitor their oxygen saturations, commonly keep their oxygen saturations between 88 to 92 in that range. We're not necessarily going to push them to 100%. That doesn't mean they can't have an oxygen saturation of 90%, but we're not going to drive to get a higher CO2. So they may or may not have wheezes. And I say may or may not because sometimes patients have emphysema alone and the nature of their airways do not cause a narrowing that causes wheezes. It causes a narrowing that prevents oxygen exchange, but they may not have wheezes. We may still treat them with a bronchodilator if we hear wheezes. Barrel chest, again, maybe. You will see these patients who are 95 years old and they've had COPD for a long time. And yes, they have increased lung fields, but it hasn't manifested as a barrel chest or an increased AP diameter. By AP diameter, I'm referring to anterior posterior diameter. So as a general rule, your chest should be wider than it is from side to side, right to left, than it is from front to back, anterior posterior. If your anterior posterior diameter increases to approximately your right left chest diameter, your lateral chest diameter, that's what creates what we refer to as barrel chest. You will observe in these patients prolonged exhalation. It takes them longer to get a full exhalation because of these tissues that aren't nice and elastic. So I like to show this picture and ask this question: what does this image tell you about serotonin? And we'll talk about that in class. So treatment for emphysema, primarily quit smoking. Now, obviously, if they're not smoking, we're not going to give them smoking cessation treatment. But for most patients, we need them to quit smoking. The challenge is if they've been smoking long enough to do this kind of damage to their lungs, the odds are that they're not going to quit at this point. So it's a big challenge, quit smoking. It's a very addictive process. Bronchodilators are the key first-line intervention here, particularly beta agonists, which help the muscles around the airways to relax. You'll see a combination of drugs used here: anticholinergics together with beta agonists. They work differently. Anticholinergics work on the autonomic nervous system or the parasympathetic nervous system, and beta agonists work on the sympathetic nervous system. We'll break this down in class and talk extensively about the nature of these drugs. Specifically, when we get to asthma, we'll break down these categories. The goal is to get as much function out of the remaining tissue as possible. So get the most out of whatever tissue is still functional. That's our primary goal. Corticosteroids are a later treatment for emphysema, and this is, in more severe cases, we have to either decrease mucus and or decrease swelling and inflammation. You'll see corticosteroids used in cases where there is a combination of lung issues going on, as I've alluded to earlier. Supplemental oxygen, with caution. You will have COPD patients who live at home on 2 liters nasal cannula or 4 liters nasal cannula. So it may be the case they need that in order to have sufficient oxygenation and not be short of breath with everything they do. And by that, I mean eating breakfast and getting dressed. So you will see supplemental oxygen here. Obviously, the therapy and the combination of therapy and the complexity of the regimen depends on the severity of the symptoms. This is a slide that we're going to break down in class. So we'll talk through all of these: the xanthines, the sympathomimetics, anticholinergics, inhaled steroids, leukotriene receptor antagonists. We'll touch on surfactants, and we'll refer to these drugs for pulmonary fibrosis. We'll refer to those when we get to pulmonary fibrosis. So we'll stop here, and our next video, we'll pick up